Dr. Dumont is one of the wunderkinds of neurosurgery. He's a native of undergrad at the University of British Columbia, went to Calgary for med school, and then trained at the legendary UVA under Dr. John Jane. He's done extensive research. He was there as an endovascular and vascular assistant professor. Then went out to Thomas Jefferson when he was there. And then at the young teenage year of 18, he came as chairman of Tulane. No, but he really got almost 200 publications. He's funded by the NIH, does wonderful basic research in aneurysms. He's a really good technical surgeon. So he's one of the rising stars. So we were very fortunate to make the time out of his schedule to be here. But he's a great guy. We also, I must add that his colleague in New Orleans is one of the dearest friends of our department, Dr. Roger Kelly, who was the past chairman of the department. So without much further ado, Harold Dumont.
Thanks very much, Dr. Nanda. It's an honor to be here. We're going to talk about aneurysms. I don't have any conflict of interest to disclose. This is the outline of the talk. We'll transition into discussing what has changed in the treatment of aneurysms over the past decade or two, and then we'll go into some of the specifics about the modalities that we use, and then finish by talking a little bit about the future and training the future generation of vascular neurosurgeons. Being from Canada, Dr. Drake was one of my heroes, and this is what he put at the beginning of his book on surgery for vertebrovascular aneurysms. If only we could have back again many of those who are lost or badly hurt for a second chance in the operating room with what we have learned. And I'll come back to this later, but I think that's important for all of us to keep in mind as we treat patients and try to do better the next time. As this audience well knows, aneurysms, depending upon the population, are relatively common, up to 10% in certain populations, and obviously rupture of aneurysms produces subarachnoid hemorrhage. Unfortunately, today still, ruptured aneurysms carry a poor prognosis. More than 10% die before reaching medical attention. It may even be higher than that. Up to 40% die in hospital. And of those who survive, only about a quarter recover completely. Based upon most recent population data, there's about 30,500 ruptures per year in the US, and it's 2 to 5-fold higher in other populations, for example, Finnish and Japanese populations. And although subarachnoid hemorrhage accounts for a minority of all strokes, 3 to 11%, it has a disproportionate burden because of the population effects, typically younger than the general ischemic stroke population. So it accounts for a disproportionate amount of life years lost through stroke. I think looking at what has changed in aneurysm management over the past 2 decades, I think of, and I'll discuss at least 6 things that I think have shaped management. The first was in 1991, this publication on GDC coils, Guglielmi detachable coils, out of UCLA, and then the first clinical work came out of UCLA as well. But I think this technology whereby coils could be placed in aneurysms and removed if it didn't work well, and then detached if it did, that was a major breakthrough in the treatment of aneurysms. And all current coil technology is based on these early principles that date back to 1991. I think the second thing is that neurosurgeons embraced the technology and became early adopters. And I showed Dr. Rosenwasser here, who was my boss for 3 years in Philadelphia, and also Nick Hopkins. I think that this was important. I think that it's important to have multidisciplinary teams, but for neurosurgeons to have a seat at the table and help develop this specialty, I think was important. And I think an analogy would be in spine, where neurosurgery and orthopedics have worked very well together, and I think a lot has come from that, from having neurosurgeons involved. Dr. Rosenwasser had finished his training, was in practice, and then went back to be Alex Berenstein's first fellow. And I think that was important for introducing the technology in the Philadelphia area, and of course Nick Hopkins in Buffalo. I think a third thing that has been important is that I showed the initial prototype of GDC coils, but coil technology has really advanced. So whereas before, you know, the first treatments or early treatments, some of them were done by placing balloons, trying to fit them in the aneurysms. And then came the coils that were basically helical shape. But now we have shapes that are very complex. We have some shapes that are coated with different materials, like Vicro suture here, PGLA, and some that are coated with gel that swells, the hydrocoils. But I think that there's been a lot of advancement in coil technologies from these early beginnings. And also I mentioned, along with general endovascular technology, there's been a lot of development in helping us get to where we need to go in order to use this technology, like the access devices are much better and we can navigate through tortuous anatomy. So I think that's been important. And this is an example of, I think, using the coil technology. This is a ruptured anterior communicating artery aneurysm that's fairly irregular, has a superiorly projecting lobe, and this is looking at it from behind, but fairly irregular. And just using standard coils and no specific adjuncts or special techniques, you can achieve obliteration of very irregular aneurysms. And I don't think that was possible you know, with the first generation of these coils. So there's definitely, I think, been a lot of development in technology. I think the fourth thing that comes to mind is that stent technology has really evolved, and it continues to do so. The first generation of stents that we use for aneurysm treatment were the first generation Neuroform, which was a major advancement. It was somewhat difficult to deliver, difficult to deploy, and I think that this has changed a lot. We're now on the, I guess it's going on the fourth generation of Neuroforms. The Enterprise stent came along, which is very easy, trackable, easy to deploy. And then we'll talk a little bit about this later, but I think the flow diverting stents, and this is a pipeline which everybody's familiar with here. The Surpass flow diverting stent that's owned by Stryker is on the horizon. The clinical trials are being completed. So I think that stent technology has tremendously evolved, and this has altered the way that I think we approach treating certain aneurysms, particularly from an endovascular standpoint when they weren't able to be treated that way before. I think that one thing that we shouldn't forget is that I think, although not as rapid or significant as advances in endovascular technology and techniques, there has been some advancement in microvascular reconstruction, and I think in certain cases cerebral bypass surgery has reemerged. And that's been tempered somewhat by flow diversion. I think there's been a trend towards retractorless surgery, less invasive approaches, complex clipping strategies for difficult aneurysms, tandem clipping, and fenestration tubes, as Dr. Lawton shows in this article, and flow reversal or bypass for complex pathologies. This was a patient that came in, had a transphenoidal, had 3 transphenoidals and radiation for a growth hormone secreting adenoma, and came in with massive epistaxis. And this was about 6 months after the last transphenoidal, and this was on the day of resident graduation. And so I went in and did an angiogram, and it showed this pseudoaneurysm here. And unfortunately, when I inflated the balloon to do a test occlusion, the patient became aphasic and hemiplegic within seconds. And this is a case, you know, now I think you can make an argument potentially for a flow diverting strategy, but you know, a bypass is a radial artery graft. This is a good solution with trapping of that disease segment where the pseudoaneurysm developed is something to consider, and I think that there have been advancements in this over time. I think the sixth thing, and we'll spend a little bit of time discussing 2 trials that I think have shaped the way that we treat ruptured aneurysms. The first of which, and I say especially, is the ISAT trial, which we'll spend just a little bit of time going through. This study was published in Lancet in 2002 with an update in 2005, and then the most recent in Lancet Neurology in 2009. And this was a study, international prospective randomized trial comparing clipping with coiling for acutely ruptured aneurysms. And patients were eligible, this important point, if their aneurysm was deemed suitable for effective treatment with either method. And this is in distinction to another trial we'll talk about in a minute, the barrow ruptured aneurysm trial. So as a result, only about a fifth of screened patients were enrolled in the ISAT. The predefined endpoint of this study was the percent of patients who were dead or dependent, defined as a modified Rankin score of 3 to 6 at 1 year. And this was assessed by a questionnaire mailed to patients and/or caregivers. And the secondary outcomes included rebleeding from the treated aneurysm, as well as risk of seizures. So as a result, 2,100 patients were enrolled, matched between the two treatment modalities. And the main message that emanated throughout the community was that, and throughout the world, was that at 1 year, 23.5% of coiled patients versus 30.9% of clipped patients were dead or dependent at 1 year. And perhaps not surprisingly, the risk of epilepsy was lower in the coiled group, with a relative risk of about 0.5. This is difficult to read, but this shows rebleeding from the aneurysm, and this is the Kaplan-Meier plot. The main message is that the risk of rebleeding was higher for the endovascular group compared to the clipping group, but overall pretty low. The rate of rebleeding from coiled aneurysms was still low. It was higher than the clipped group. So in the follow-up study that was published in Lancet Neurology in 2009, the risk of death at 5 years was still lower in the coiled group, 11 versus 14%, although most of these deaths were due to cardiovascular cancer later on. There was no difference in probability of independence at this 5-year time point, 83% versus 82%. There have been a lot of post hoc analyses of this from data accrued from the study, which has its own limitations, of course, but also not surprisingly, late retreatment was about 7-fold more likely after coiling compared to clipping. They wanted to look at aneurysm outcome by age group. In elderly patients, there didn't appear to be any overall difference in outcome between clip versus coiling, but then they looked at this by location, and PCOM aneurysms tended to have better outcome with coiling, MCA better outcomes with clipping, and the epilepsy was higher in the surgical group, 13% versus 0.7%. Another study that was published in the Journal of Neurosurgery based on this data is that they wanted to look at the advantage of coiling specifically for patients in less than 40 years. So this analysis took into consideration, well, what's the risk of retreatment, aneurysm recurrence, and potential rebleeding over the lifespan of patients who are young, less than 40 years old. And they concluded that it could not be assumed in this particular population. And again, this is a post hoc analysis, so there's limitations to this. The study was not designed to answer these questions up front. This is a hot topic now in today's healthcare environment, but they also looked at cost effectiveness at 1 year, and endovascular treatment was more costly, but associated with better outcomes, at least at the 1 year time point. And then others looked at cognitive outcome in coiled compared to clip patients at 1 year, and there were better cognitive outcomes, at least in the outcome measures assessed in the coiled compared to clip group at 1 year. If we look a little bit further into this study, it is largely a European study. Almost all the enrolled patients were from Europe, and more specifically, 5 centers enrolled over half of the patients. Again, as we discussed earlier, almost 80% of screened patients were not enrolled, and there was a preponderance of good grades, so 88% were WFNS grade 1 or 2. And whether or not that's representative of the population that we commonly see, at least at most centers, remains uncertain. Of course, because one of the criteria were aneurysms had to be deemed equally suitable for treatment in either groups, there was an underrepresentation of MCA aneurysms. And I think at most practices there's a skew, and we'll talk about this, towards clipping of those aneurysms. There was a high variability in percentage of the patients enrolled by centers. One center enrolled 44% of the patients. There was a minimum criteria for endovascular therapists. They had to have treated 30 aneurysms, but there was no similar requirement for neurosurgeons in clipping. And there's been some discussion that overall the results were poor in the surgical group, and there was no report of procedural complications. Despite that, I think overall this was a well-conducted trial whose results apply at least to the specific population of patients studied. And there's some coming out of Canada. There's apparently this has already started, an ISAT 2 that's trying to look at patients who were not covered in this particular study. And the long-term follow-up is ongoing, and as mentioned, the generalizability of these data remains to be determined. How does this apply to the population of patients we see every day? But there's no question that this is a critical study that has shaped practice throughout the world. The barrel ruptured aneurysm trial, I just wanted to spend a couple of minutes discussing this because this is a recent study that has come out. And this was designed very differently, as I alluded to. So a classic randomized controlled trial is that there was verification at the beginning to make sure that the patient is eligible for both options. So as shown, there's frequent exclusions. Over 80% of patients were excluded from the ISAT, for example. And then informed consent for research is given. Then the patients are randomized, and there's relatively few crossovers. Patients consent to treatment after they've been allocated, randomized to the treatment group, and then this analysis may be more straightforward. The barrel ruptured aneurysm trial was designed differently. This was a pre-randomization model. The idea was to try and enroll as many patients as possible with as few exclusions as possible. So the patients were actually randomly allocated before giving consent. So they're randomly allocated to surgery or coiling. With this model, most of the patients were captured, but the problem with that is if you were allocated to coiling but weren't suitable for coiling, then you could cross over into the surgery group. And so as a result, as we'll see, there was not infrequent crossovers, and this may make analysis in the end, because of crossovers, more complicated or with other considerations to consider. So the purpose of the BRAT study, for short, was to compare the safety and efficacy of microsurgical clipping and endovascular coil embolization for the treatment of acutely ruptured aneurysms. And the null hypothesis was that no difference exists between the treatment modalities. And here's the breakdown. 725 patients were screened, 500 eligible patients were enrolled. Patients were assigned in alternating fashion to clipping or coiling. Initially it was based on the call schedule because it alternated night to night, and then by a number system later on in the study. Intake evaluations and outcome measurement were collected by nurse practitioners independent of the treating surgeons. And for the residents, I know that you guys already know this, but it's important for outcomes to be adjudicated by independent individuals from those who provided the treatment. 238 patients, as a result, were assigned to clipping and 233 to coiling. Crossover was allowed, but the primary outcome analysis was based on the initial modality assignment, so it's an intent to treat analysis. The post-treatment care was standardized for both groups. The primary outcome measure, similar to ISAT, was outcome at 1 year, death or dependency at 1 year. Secondary analyses, results based on actual treatment versus intent to treat, aneurysm-related rebleeding, retreatment, and death, and initial degree of aneurysm occlusion. So this is the flow of patients. 500 consented to be in the study. There was 28 consented in error, so 472. And then those assigned to clip, those assigned to coil. The actual number who were assigned to coil that actually received coiling was 62%. So 124 of the 233 were assigned and actually received the coiling treatment. This is a busy slide, but it just shows that the groups were well matched with respect to common demographic features as well as clinical grade. This was the main message from the study. So the proportion of patients with poor outcome, modified Rankin 3 to 6 at 1 year. Of those by intention to treat, 34% in the CLIP group had poor outcome at 1 year versus 23% in the coiled group. And this is not dissimilar to the ISAT study if we look back to it. And then you can look at it by what they actually received. I think the difference is even more marked if you look at those who were assigned to coiling who actually received coiling. The difference is even more significant. They did a multivariate analysis to look at predictors of poor outcome at 1 year, and clipping was one of those factors with an odds ratio of 1.72. Age greater than 50, which is a commonly known potential predictor of poor outcome, and poor grade, higher grade was associated with poor outcome. So one thing I found interesting, if you looked at retreatment of aneurysms at 1 year, the only thing I'll bring up is that coiling obviously is more common. If we looked at actually those who received coiling, the rate of retreatment at 1 year was 11%. What I couldn't quite figure out, and I went back into the paper, is if you look at the actual patients who received clipping, they were retreated during the hospitalization, and these are expert surgeons, in 4% of cases during the hospitalization. So I found that, I couldn't find a good explanation for that, for aneurysms to be retreated during the same hospitalization. So the conclusions from the 1 year data were that poor outcome was more common in CLIP compared to coil at 1 year with an odds ratio of 1.7. They concluded that a policy of intent to treat favoring coil embolization resulted in fewer poor outcomes than CLIP occlusion. And although most aneurysms assigned to coil were treated by coil embolization, there were a substantial number of crossovers, as we discussed, 38%. And it remains important that high-quality surgical clipping be available as an alternative treatment modality. Then they had a follow-up at 3-year data, and I'll just briefly mention this. The risk of poor outcome in patients assigned to clip versus coil had decreased and was no longer significant at this time point, at 3 years. But it's interesting to note that deterioration in some patients assigned to coiling but who underwent clipping had late deterioration, changing them from a modified Rankin score of 2 to 3 due to difficulties with concentration, memory, and depression. And I think an important thing is that this study is probably underpowered to look at this, that small numbers at the 3-year time point were limiting, so follow-up is ongoing. Interestingly, the difference, even with relatively small numbers, was significant. The difference persisted for posterior circulation aneurysms at 3 years. So, also not surprisingly, the CLIP group had a higher degree of aneurysm obliteration and lower rate of recurrence and retreatment. So I think in conclusion from the BRAT study is that overall it was an important study that has provided additional information concerning the treatment of ruptured aneurysms, and it was designed differently and executed differently, obviously, than the ISAT. Like all studies, methodological issues introduce limitations, and I think at least this data should be considered in the counseling of patients and their families with ruptured aneurysms. So if we go back, this has limitations. I had worked with a medical student looking at discharges using the nationwide inpatient sample, just looking at aneurysm treatment methods, but I think it underscores what I was trying to bring up. The ISAT results were first published in 2002, and if you look at the rates of coiling and clipping in the United States, and this includes ruptured and unruptured aneurysms, I think that there's little question that the ISAT has had a significant influence on, treatment in this country, and particularly in Europe, where some centers have more than 95% of their aneurysms treated with coiling. So moving on I'll talk a little bit about the decision to clip or coil. And I think an important message is that the overall treatment goal for an individual patient with an aneurysm is to provide the safest, most effective, and durable treatment that can be applied with the lowest associated risk. So although we talk about coiling versus clipping, it's not really a competition of clipping versus coiling. These are different tools to treat the same condition, and the real competition is using all of our tools to treat a given patient with an aneurysm to try and achieve the best possible outcome for them. So we know that microsurgery is durable, it's effective, and we have a lot of long-term data to support this. Its limitations are that it's invasive or more invasive than the endovascular route. There's some element of brain retraction, although we've attempted to minimize that. There's difficult to access certain locations, potential for perforator injury with an exovascular versus endovascular approach, and potential for cranial nerve injury. Endovascular treatment, and the main focus is coil embolization with or without balloon or stent assistance, flow diversion, which we'll briefly talk about, and liquid embolic agents, which are not used very much now, the Onyx HD 500 with flow diverters available. It's less invasive, we know, the endovascular approach, more rapid recovery, overall an excellent safety profile. And its current efficacy appears satisfactory with at least midterm follow-up. Obviously, we don't have the same amount of follow-up as with microsurgery. Its limitations, durability is always cited as a potential limitation. Recanalization, coil compaction, hemorrhage after apparent complete occlusion, which is probably exceedingly rare. Wide-necked aneurysms remain challenging. MCA aneurysms, or aneurysms where there's incorporation of branches into the aneurysm itself. And this is probably not fair. Giant aneurysms remain difficult to treat, potentially with both treatment modalities, although I know Dr. Nanda's experience recently published is superb. Patient selection, I think when we look at factors that go into the decision-making process, obviously age, if patient has a rupture, clinical grade, comorbidities, and life expectancy, particularly for unruptured aneurysms, looking at the cumulative risk of rupture over a patient's life. Aneurysm-specific factors, so size, location, neck width, dome to neck ratio. I think presence of calcification is important, especially for microsurgery, presence of thrombus within the aneurysm, incorporation of vessels into the aneurysm or multiple aneurysms. And more, I think that patients and families come with a preference, and that is taken into consideration, I think, in counseling. Patient selections generalities, I think that this is true of many centers in the U.S. Basilar bifurcation aneurysms and most posterior circulation aneurysms and endovascular treatment approach is preferred. Middle cerebral aneurysms, I think also at most centers, microsurgery is generally a first-line consideration. And then other aneurysms, decision made on a case-by-case basis with coil embolization preferentially recommended for ruptured aneurysms when they may be suitable for both methods. One thing we discussed during the case presentations was use of stents in the setting of acute subarachnoid hemorrhage, and the issues particularly with EVDs and converting to a shunt when necessary and stopping antiplatelet therapy or given platelets. I think it at least gives pause if you're considering treating an aneurysm with a stent in the acute setting. I've done it numerous times when I didn't think that there was another good option, but if you can use a balloon or clip the aneurysm, that may be a better option depending. So just to go through some cases, this was a patient who presented with a seizure, was working at a golf course and had this seen on the CT scan, and has this aneurysm which appears to arise from M1. It's quite dysplastic, and this is what the aneurysm looks like here, but this is proximal, distal, and large aneurysm encompassing a large circumference of the M1 trunk. And this guy didn't want surgery no matter what. He wanted some kind of endovascular treatment option, which I didn't think was a good idea. But what we did was placed a stent. This was a single enterprise stent was placed across into this M2 here, and then we coiled the aneurysm. This is actually the 1-year follow-up. I thought for sure that this would recur, was not a good solution, but at least up until this follow-up seemed to be a decent solution. This is an example where the patient's strong preference was not to undergo surgery, and if it was surgery, it would be a fairly complex reconstruction and potential need for bypass and so forth, or nowadays, consideration for pipeline could be given, but the concern of the lenticular striate perforators and the uncertainty with that makes that a limitation. I think there's a fairly broad neck basilar bifurcation aneurysm. The stent technology, as I mentioned, has gotten a lot better. So this patient presented, actually this is acutely ruptured aneurysm. And what I noticed, there was a PCOM here, and one solution would be to place a stent across the basilar bifurcation and then coil through that. We tried coiling it without, and this is with our catheter in the carotid going back across the PCOM into the PCA. There's a microcatheter injection. And then we've laid the stent basically from PCA to PCA, and then we're able to coil it like that. This is another example of a ruptured aneurysm. I rarely use stents in acute subarachnoid hemorrhage, but where this one was treated through a similar technique, PCA to PCA stent and coiling. And I show this because the stent technology has gotten so much better. With the first generation, there's no way you could track the stent out there and deploy it like this. So rarely, I think, in subarachnoid hemorrhage, stents have a significant role. I think another good example where endovascular treatment may be preferable, if suitable anatomy, is late recurrences after previous clipping. For example, this anterior communicating artery aneurysm here. You can see the old clip in place there. And this is where the aneurysm was coiled, and surgery may have been more difficult to go back in, reopening a craniotomy from decades ago and clipping that. So I think that this has a good role if the anatomy is suitable. We talked about MCA aneurysms and the preference for clipping. This was a patient who came in with neurogenic stunned myocardium, was very sick, EF I think 10% or less, and has this broad-necked ruptured MCA aneurysm. And this is the 3D. It's not real good quality, but this branch is not at play. It's this branch that loops around the back of the aneurysm. It's shown here. And we used a balloon and coils to treat this in the acute setting. The guy was real sick. But I quote Dr. Jain here because he says, quoting WH, on prohibit sharply the rehearsed response. So not MCA aneurysm doesn't always mean clipping, that in certain circumstances, coiling may be a very good solution. Looking at roles for microsurgery in 2014, I think that, and we'll talk about this with implications for training, roles for microsurgery: complex aneurysms, those that are wide-necked, involving branches at the base, requiring reconstruction or bypass; ruptured aneurysms with hematoma; endovascular failures, potentially young patients; and unruptured aneurysms. And patient preference that we discussed before. There's a patient who came into the ER, began to blow their pupil in the ER, has this big hematoma, and we got a CTA at the same time that shows that, that there's this MCA aneurysm where the irregular teat on the dome projects directly into the hematoma. And I think that this is a good example where microsurgery plays a big role. Take them acutely, evacuate the clot, coil the aneurysm. I don't think this was, I mean clip the aneurysm, evacuate the clot, and we did a craniectomy here. I don't think this is suitable for coiling, although I've had some colleagues that have said, well, let's coil the aneurysm, secure it, then we don't have to go in and clip it, and we'll just take the bone off and evacuate the clot. I think in this case the guy was herniating, and that probably wasn't a good option, but I think when there's a big hematoma, to clip the aneurysm, take care of the clot at the same time. I think some aneurysms evade typical surgical options or endovascular options. This was a young guy who presented with ischemic stroke symptoms, trouble with speech and right-sided weakness, has this lesion here with some calcium and so forth, looks like some thrombus maybe. That's not a good view, but this is the angiogram, and this is a young guy, and what's interesting is that the M1 is here, it goes into the aneurysm, and then there's these pipes that come out of it, which are very, very large and abnormal, extremely large. And I don't know of a simple endovascular solution for this because two branches come out of it, so you can talk about pipeline, flow diversion, etc. I think surgery options you can explore and try to reconstruct it. I think there's a lot of atheroma in it. But my thought was to basically reroute flow by occluding M1 after some type of distal bypass, and hopefully the aneurysm will thrombose, and if not, we can go up through the graft, retrograde, and coil it. And I'll see if this video plays here. it's more interesting because of the surface of the vessels were so abnormal. So this is left pterional craniotomy. This is actually a cortical MCA branch here, and it's atherosclerotic. This is a 27-year-old guy, and I'll just show the video. Dissecting the arachnoid around it. And it's just that it's opening a sylvian fissure. So these are those distal vessels, and that's actually the first hint of the aneurysm here, this yellow atheromatous lesion. I'll pause it here. That's the aneurysm there, opening a fissure. But what's interesting is the vessels are completely normal. So the supraclinoid carotid here is normal. The MCA is normal up until the aneurysm, and then all the distal vessels are dysplastic and atherosclerotic. So we've exposed M1 going into it, and this is doing a radial artery graft. And I tried to sew it into this vessel initially, but I couldn't get the clips to seal it because of atheroma in it. That's the neck part where we did the anastomosis. And that's taking off the clips. So that's the radial artery being sewn to the external carotid. That was the ICG, but the result was somewhat surprising. We did a post-op angiogram, and I didn't think that it was thrombosed so quickly. But this is the clip on M1 going into it. These are some of the lenticular striates filling. And we tried to occlude it just before it got into the aneurysm, just distal to the last lenticular striates that I could see. And here's the graft going up and retrograde filling the distal MCA territory. And I thought some additional treatment would be necessary. So this is an example where I think traditional treatments, I'm not sure what a good traditional treatment is, but rerouting flow can sometimes be a good option. Just a note, we talked about posterior circulation aneurysms being most commonly treated endovascularly. And back when I started at UVA, our policy for these was endovascular first if possible. Although there's some argument, you know, Mike Lawton published a paper on microsurgery for pica aneurysms, and we had some editorial going back and forth, and his thinking is that microsurgery is the first line for this, and he may have some, there may be some merit to that. We had some challenging recurrences. I'll just show an example here. This is a young woman, subarachnoid hemorrhage, has this aneurysm here. There's a lateral view after the coiling, and decent result. The parent pica is patent. We did a follow-up, and it may be a little hard to see, especially at the back, but the coils have compacted up. And the concerning part is that there's a new lobe that projects anteriorly here that was not on the initial angiogram here. There was no anteriorly projecting lobe here. And so now this is difficult. I don't think that you could recoil that because you're going to take the pica, and if you take the pica in this segment, the anterior medullary, there's a risk of medullary stroke. So what I wanted to do is explore it and see if we could reconstruct it. So this is at surgery. This is the pica coming out of it, the parent vert here. That's that anteriorly projecting lobe here that wasn't there before. No matter what I did, fenestrated clips, clip above the pica, below, the pica always occluded. And on the opening, I had dissected the occipital artery, and unfortunately, we must have damaged it because there was no flow through the occipital artery when we cut it, because our plan was to take pica after we did a bypass distally, and but we must have injured the occipital artery, so then we sewed the pica vessels together, a side-to-side pica anastomosis, and that appeared to work okay. That's not a good picture, but that's the completed anastomosis, and then we clipped the aneurysm, but it shows that the aneurysm is occluded, and here's the bypass that fills both hemispheres. Whether or not that's necessary, whether or not you could just take pica, I'm not sure, but it runs the risk of potential damage to the perforators if those are occluded. So there's arguments either way, but this seemed to be an okay solution. But if it was clipped in the first part, then all this business of going back in and bypass probably wouldn't have been necessary. Another area of controversy, I think, especially with flow diversion, is microsurgery. And I know Dr. Nanda has a very large series of paraclinoid aneurysms. We know that we can coil giant paraclinoid aneurysms. When they present with visual loss, the question is that going to make it worse? And I don't think we know that. So we can take aneurysms, fairly large aneurysms, coil them or stent coil them, and technically that's feasible. Whether or not that has a higher chance of good visual outcome, I'm not sure. This patient actually was diagnosed with a pituitary lesion initially, and luckily we didn't biopsy it or go in, but they had this large aneurysm that was compressing the chiasm and had a bitemporal hemianopsia, and fairly large, projecting medially. And I think here now, you know, the options here, this was I think she was 47 years old. She was the teacher of one of our residents' daughters. And the options here are to coil it. Pipeline now, I think, would be a reasonable option. I just don't know when they present with visual loss what the optimal thing is, but I think that microsurgery can be a good option. This is the post-op angiogram. You can't see it well, but we stacked multiple fenestrated right-angle clips to reconstruct it. We exposed the neck and did retrograde suction decompression to collapse it and so forth. And that was a good, her vision got better. I think that was a good option. Of course, there's risk of visual loss with surgery. But we shouldn't lose sight of the fact that that's an option for patients with these large aneurysms, even today, and maybe we could call this an endovascular era. We talked about flow diversion. It may hold promise. I'm not sure. You know, certainly we've done a lot of pipelines, but this is a 11 millimeter ophthalmic, and you can get a good result with obliteration and preservation of the ophthalmic artery. Mind you, you've committed the patient to at least 6 months of dual antiplatelet therapy, in-stent stenosis in the long term, not sure about. And we have seen visual loss from emboli out the ophthalmic artery, although rare. So that's a consideration, I think. This was a patient that 66 years old, had some medical problems, headache, multiple cranial neuropathies, this large aneurysm here, failed to test balloon occlusion very quickly. And this is one where we placed pipelines across it, and this is the immediate result, and then long-term result, where there's complete reconstruction of the diseased vessel. So that was at 6 months, and the cranial neuropathies improved. You know, this would be difficult to treat, I think, without flow diversion, and I think that there was a pendulum swing towards flow diversion, and people are looking at it critically now, and it may swing back the other way a little bit, but I think there is some role for it, such as in cases like this. Occasionally we, I'll just skip through this one. Sometimes we, depending on your level of expertise, there's a patient who presented with a large subarachnoid hemorrhage and 2 aneurysms, and I couldn't tell which one bled. There's this irregular basilar bifurcation aneurysm and this pica aneurysm, which we'll see better here, shown here. And there's some irregularity here, fairly large. And so what we elected to do, and you know, you could argue that you could clip both or coil both. I thought that, you know, we coiled the basilar okay, and then we went on to clip this aneurysm, maybe because I was skewed from some of the other experience with pica recurrences. So the post-op after clipping that one. So we can use both sets of tools to treat a patient using all the tools available, basically. Now, a little bit looking towards the future, and I'll just talk about research for a moment. You know, obviously microsurgery is potentially invasive. These giant aneurysms are difficult to treat, and you know, the question is, are there alternatives? This also caused me to think a little bit about this. There's a subarachnoid hemorrhage here, a small one, and had a PCOM aneurysm which was coiled. And then has 2 other aneurysms on the other side, an anterior choroidal and an MCA aneurysm. So 5 years later, she comes back with a new subarachnoid hemorrhage, was lost to follow-up, and a decent-sized hemorrhage, and there's some hemorrhage here within the gyrus rectus. And what we found was that the source of bleeding, which shouldn't be predicted by, I mean, this shouldn't have been what happened. There's a tiny bleb here. 5 years later, has a decent-sized carotid bifurcation aneurysm that was the cause of this new hemorrhage. And ISUIA or other studies would have predicted that those ones on the other side, if they were going to rupture, should have ruptured, not that 0.5 millimeter bump that you couldn't even definitely call an aneurysm on the initial one. So I think our current understanding of biology of aneurysms is inadequate. I think we need to understand this, however, to select which patients to treat when an unruptured aneurysm is found, and also to develop non or minimally invasive therapies for aneurysms. And I'll just briefly mention that inflammation may play a role in aneurysm formation and progression. We see macrophages, lymphocytes in the aneurysm walls, elevated levels of MMPs. TNF-alpha may play an important role, and that's where some of our research is focused on. We focused on smooth muscle cells. They're a constituent of the vessel wall, and we know they play an important role in atherosclerosis. But they're unique because they can switch phenotypes. They can go from a differentiated phenotype, which is principally concerned with contraction, and they can be modulated to be in a phenotypically modulated state where they produce excess MMPs, inflammatory factors, and so forth. And one of my thoughts was that this may contribute ultimately to breaking down the vessel wall and leading to aneurysm formation and eventually rupture. And so the idea is that they start as healthy smooth muscle cells in response to, for example, environmental factors such as smoking, hemodynamic factors. They change phenotype and become different, where they produce inflammatory factors, reactive oxygen species, MMPs, and then the end result is that they die, and then this may lead to aneurysm rupture. We've been interested in some of the molecular mechanisms, which I won't go through, but some of the smooth muscle contractile proteins have control elements in their promoter regions, and one of our thoughts was TNF-alpha may result in alterations that result in phenotypic switching. So we looked at some of this with treating cells with TNF-alpha, and these are the contractile proteins. Treating them with that decreases the expression of these contractile proteins, but markedly increases the expression of some of the factors we think may play a role in aneurysms, such as MCP1 that attracts macrophages, monocytes, and some of the MMPs. So we wanted to look at this in vivo, and the first thing we did was treated carotid arteries with TNF-alpha to see if it recapitulated some of these findings we found in smooth muscle cells, and then we took rats and induced aneurysms with a model that results in spontaneous aneurysms to form. Basically, we ligate one carotid, make them hypertensive, and it seemed like TNF-alpha had some role. Another model of aneurysm formation that we've used that has some distinct advantages is basically this model here, where we inject elastase stereotactically into the basal cistern around the carotid. We do a nephrectomy and give a corticosteroid, mineralocorticoid, to increase pressure, feed them a high salt diet, and use BAPN, which inhibits collagen cross-linking. They form spontaneous aneurysms. But more importantly, these aneurysms rupture, and you can grade them accordingly, but this is an example of a spontaneous rupture in this particular model. The model I had briefly mentioned earlier doesn't develop aneurysm ruptures. They form aneurysms, but they don't spontaneously rupture. So we wanted to look at this TNF-alpha to see if it played a role, at least in this animal model, based upon some of our in vitro work. And so we designed an experiment where we'd induce aneurysms to form, and we'd have three groups: wild type, TNF-alpha knockout, and then this is a TNF-alpha inhibitor. And we'd look at aneurysm formation and rupture in these groups. We found that in this model that the groups equally developed hypertension, which is necessary for aneurysm formation and rupture. And what we found was that compared to vehicle, the TNF-alpha treated with the group treated with the TNF-alpha inhibitor and the TNF-alpha knockout didn't develop as many aneurysms, and furthermore, few of those aneurysms that form ruptured, so compared to the wild type. The incidence of aneurysm formation and rupture is about over 80% in the wild type model, and less than 40% and almost less than 30% here in the TNF-alpha knockout group. And if we looked at the incidence of aneurysm rupture over time, there's a marked difference between the vehicle-treated and the TNF-alpha inhibition strategies. We harvested some of the aneurysms in these mice, and we found that in the unruptured aneurysms, TNF-alpha expression was significantly increased, and in the ruptured aneurysms, markedly increased. But the summary from this research is that I think understanding the mechanisms underlying aneurysm formation and rupture, we may be able to use this to translate better therapies for our patients. We have no medical therapy for aneurysms at this time. And now just to transition to the final part of the talk, I think the future of aneurysm treatment, a lot of advances in these areas of medicine and engineering and so forth will go into developing better minimally invasive therapies, medical and endovascular. But microsurgery will continue to have, I think, an important role in treating patients, although a minority. But the main developments, I think, we'll see in this area. Now, just to conclude on training the next generation of vascular neurosurgeons, we know that resident duty hours have been reduced throughout the world, and in Europe especially significantly. We also know the absolute numbers and relative proportions of open aneurysm surgeries have decreased. And unfortunately, the aneurysms that do go to surgery are more complex, and sometimes endovascular failures and so forth. And I showed this slide earlier. This is just by discharge again, coiling compared to clipping in the US. This poses challenges that we need to figure out an effective solution for. So I think one thought is to concentrate aneurysm treatments at high volume centers, as you guys are here, you know, regional referral centers. And one thing that's interesting is that there's good data that patient outcomes are strongly influenced by volume at the treating center. And I find it interesting, well, I guess it's state dependent that lawyers haven't gotten a hold of that in some circumstances, but you know, I think one strategy is to have them concentrated at major centers, which are often teaching facilities. I think that it's important to maximize the educational experience afforded by the open aneurysm surgeries we have. So I've seen some of the things that companies can do now, create preoperatively three-dimensional models that you can sit with and actually hold and rotate into the surgical position. There's also, of course, on computer as well, but you can see what type of clip you may use and stuff. So I think that that may help to maximize educational experience, and of course preparing for the case as a trainee. I think that simulation and microvascular laboratory training, I think the simulations are getting pretty good. I don't think they're there yet, but microvascular laboratory training, I think Yasser Gill has talked about this for many years, that this was essential that he did this before going in to treat patients. Fellowship training, this is an area of controversy. You know, whether or not these skills can be learned during residency or whether there has to be dedicated training afterwards. And now to come back to where we started, I'll end with this case. This was a patient who came in with bad headaches, unruptured aneurysm, carotid bifurcation. I don't think that there's a good endovascular solution for this. I didn't see a real large anterior communicating artery that will come to bear in a moment. We treated the aneurysm, we clipped it. This is an intraoperative angiogram. The aneurysm is occluded, but the problem is I don't see the anterior cerebral artery filling, antegrade. When I inject the left carotid, you can see that both A2 segments seem to fill, or both hemispheres of the distal ACA territory appear to fill. And what happened is that the patient was discharged out of the ICU on post-op day 1 to the floor, but on post-op day 2 became acutely weak while walking to the bathroom. And you can see that there's an infarct in this region here, which may be Hubner. And unfortunately, she went on to develop this start of an ACA infarct, and then this complete ACA infarct, devastating injury from this. And I think what happened, you know, we did a CTA and so forth, is that the ACA probably retrograde thrombosed. And what I learned from this is that, and I tried, but it would have been important to restore antegrade flow through that ACA, and maybe that would have avoided this. But that brings us back to where we started when I quoted Dr. Drake. If only we could have back again many of those who are lost or badly hurt for a second chance in the operating room with what we've learned. I think that's, I tell the residents that's important to keep in mind. How can we do better tomorrow? In summary, cerebral aneurysms remain a devastating disease. I think our understanding of aneurysms has evolved, although much work is left to be done to help improve patient outcomes. I think endovascular therapy has been shown to be a safe and effective method of treatment for acutely ruptured aneurysms, and in other literature, obviously in everyday experience, unruptured aneurysms as well. Microsurgery remains an important option in the treatment of aneurysms and will remain essential for the future. And I think well-trained vascular neurosurgeons are desperately needed for the patients of tomorrow. And that means we have to overcome some of the obstacles that we have now as a result of the climate and training the next generation. Thank you.
Thank you for a great talk. Any questions? My question is that smoking is always an important feature for me in determination, because I think heavy smokers, the coiling results, the recurrent disease is much more common. So for young smokers, I tend to favor clipping. Do you have any biases on that, or how, because people are not, especially in Louisiana, they're not going to give up smoking that easily.
Yeah, I found that out. Yeah, I think that's important. There was, some of the work came out with out of Philadelphia where they showed that the rate of recurrence is higher. I think that's important to consider. That young smokers maybe clipping is a better option, especially if they can't quit smoking, which many of our patients, of course, can't.
Yes.
Quick question. I know you guys never do this, but do you think the epilepsy would be microsurgery because of retraction, laceration, contusion? Because you shouldn't get that much from seeing residual epilepsy.
Yeah, I think that plays a role in it. Yeah, something to do with the surgical procedure itself.
No one's really looked closer.
No.
If neurologists did it, there'd be no seizures.
If I did it.
The great nemesis of ruptured aneurysm, vasospasm. I would not mention that. I assume that's under control and not a problem.
Yeah, I think it's still a problem. It seems to be perhaps less of a problem now, but it still continues to be a problem. Sometimes we get recalcitrant vasospasm, especially in younger patients with very thick clot that takes a while to clear. We don't have a good solution for that. Still today, like there was the CONSCIOUS 1, 2, and 3 study that looked at an endothelin antagonist that looked very promising, and it didn't change outcomes. So I think that it's still important. There's some shift now towards maybe large vessel spasm is one component of this deterioration that develops in delayed fashion, but there's other things that may contribute, microemboli, spreading cortical depression, things like that. We haven't solved vasospasm.
Would you think that the endovascular manipulation would have any effect on vasospasm, making it worse perhaps or less?
Yeah, the answer is it's controversial. We published a paper in Stroke that looked at the CONSCIOUS data that showed that endovascular treatment was associated with significantly lower incidence of symptomatic vasospasm. And others have shown that, but then there's been some controversy that there's no difference. So I would say that it's an area of controversy, but there's a suggestion that endovascular treatment may be associated with a lower incidence, but that's certainly not well established.
What's the role of nitroglyceride in the vasospasm?
Yeah, that's a good question. I don't know. We know that endothelial eNOS is downregulated acutely in subarachnoid hemorrhage, and there may be a relative imbalance between shortage of nitric oxygen and overactivity of endothelin. One of my partners when I was at the University of Virginia, Ed Oldfield, did work with sodium nitrite as a NO donor. And actually there's a phase 2 study that started in humans that's looking at it. So I think that probably there's a deficiency, and you know, maybe this sodium nitrite will be a partial solution for that.
Because in the past they used to say that when you have a gland over there, the gland is absorbing the nitric oxide, so you don't dilate the vessel, it will collapse.
Yeah, yeah.
What's your routine treatment for vasospasm?
Well, ours is, you know, we give nimodipine beginning on day 1. We keep patients normal bulimic, and we screen with TCD, and if symptoms develop, you know, then we begin hypertensive, hypervolemic therapy, and if that quickly doesn't resolve a deficit, then endovascular. But we don't give routinely statins. You know, there's some literature that has looked at that. We try to keep magnesium normal, but we don't make it super therapeutic. I don't know your thoughts, Dr. Nanda, on it.
Do you use isradipine on nidardipine? Because the namodipine has been used demonstrated that it doesn't do anything to the vasospasm.
Yeah.
Well, we're using nimodipine, it's the only published
No, but
thing.
that's
Yeah. We have magnesium, I think after residence. Are we doing much? I don't think we are. Yeah.
What about when we used to inject when we have a capillary?
We use intraarterial stuff.
Yeah.
There's vasospasm, and Dr. Cuellar will
What do you-
inject
what do you
papaver.
use?
They use what are the things we're using?
Yeah.
The papaver, yeah. That's-
Yeah, verapamil, nicardipine,
Nicardipine.
some type of usually calcium channel,
And
I
you
guess
go
the
in
phosphodiesterase.
with your infrared.
Yeah. If it's severe and proximal, then balloon angioplasty to open those segments up.
Just said that.
Yeah.
What are your thoughts on one report that endovascular procedures had less cognitive impairment than microsurgery?
Yeah, I'm not sure. You know, the study wasn't designed to look at that. People have looked at this for unruptured aneurysms, comparing the two, and it's conflicting. There's some studies that have showed no difference, and it may differ based on location. I don't know. You know, I haven't. I'm not sure. You know, the literature is conflicting in that area.
The other problem is that you don't have a pre-morbid evaluation of cognition, and so you don't know really.
That's right, yeah, for the ruptured aneurysms, but there's been some studies for unruptured aneurysms where they did pre and post testing, and some have found some deficits that emerged following surgery, and some have not. So, I mean, it's something to consider.
I think Sandra Collins done a lot of work on cognition and carotid endarterectomy. They've done some good work on that. Well, thank you again. Appreciate you coming. Plaque on behalf of the father.
Thanks very much.
Thanks so much.